Hi, this is Dr. Arun Vishnar, and after a long time, I am delivering a lecture which will help you a lot, and you will able to understand from this lecture about a procedure which is known as capsular endoscopy. This is helpful to postgraduate students, practitioners. It is also helpful to undergraduates, students who are appearing for entrance examinations of the post graduation. This lecture may be helpful to them. Please listen to this lecture properly, and please give your comments at the end of lecture what you understand from my lecture, whether it was helpful to you or not. So I will be talking about capsular endoscopy. By the end of this session, you will come to know about the technical components of capsular endoscopy. You will come to know about the uses of capsular endoscopy. You will come to know about indications and contraindications of capsular endoscopy. You will come to know about, in short, about the procedure. So, this capsular endoscopy is usually done to study the small bowel pathologies, because this small bowel location of this small bowel is in such a place in body, and it is quite a long region of GI tract, so it is very difficult to visualize this region, though we can nowadays we can visualize with the help of enteroscope, but it is too difficult. So this procedure of capsular endoscopy is relatively easy procedure, with the help of which we can study the bowel problems, small bowel problems. Now this capsular endoscopes, these are of various types. In one type of capsular endoscope, the cameras, the diode cameras which are containing LED light is located in the capsule. It sends the light, and this light reflects from the bowel wall and is recorded in the recorder, which is tied to the abdomen, which is with the help of a belt. In one case, the capsule is itself recording the images, and it has to be retrieved after the procedure and then studied on the computer. So this was in short about the capsular endoscope and how it. Now, what is the pre-procedure assessment? In pre-procedure assessment, prior to doing this capsular endoscopy, you should first obtain informed consent, and before taking a consent, discuss the purpose and nature of the process with the patient and his relatives. Now tell them about indications and contraindications. Alternatively, other procedure which can be used instead of this capsular endoscope should be discussed with the patient and his relatives. Now you will have to talk about the bowel preparation which is to be done in that particular patient. Quality of bowel preparation should be discussed, and medications which will affect the procedure should be discussed with the patient. Diseases which affect the procedure should be discussed with the patient. So this is the pre-procedure process which should be done in the case of this capsular endoscopy. Now, what are the indications for this capsular endoscopy? In which patients this capsular endoscopy is indicated? Whenever you are suspecting a small bowel bleeding, occult bleeding, which cannot be seen, which is not clinically detectable, then in that case, capsular endoscopy is done. Together with occult bleeding, there is chronic anemia. And the cause of anemia, you are not able to detect the cause of anemia. Then in that case, a small bowel endoscopy is indicated. If there is overt bleeding, that is melena or hematochezia, by doing colonoscopy, by doing upper GI endoscopy, if cause is not detected, that means there is some problem in the small intestine. So in this case, you can go for capsular endoscopy. In screening and surveillance procedures of active Crohn's disease, if patient is a case of Crohn's disease and disease is active, then in that case you can do this capsular endoscopy to see the progress of disease, the effect of treatment, and the complications of Crohn's disease in a small bowel. This is also helpful in studying polyposis syndrome, in celiac disease, in malabsorption syndrome with a unknown cause of diarrhea. Then in that case, this capsular endoscopy is helpful. Now there are certain contraindications to this capsular endoscopy, and these contraindications include any obstruction in the GI tract. Either there is obstruction in stomach or in esophagus, anywhere if there is obstruction, then in that case this capsular endoscopy is not to be done. If there is some stricture, then it should not be done. It is unsafe to swallow this capsular endoscope capsule in obstructive dysphagia. That is, if there is some obstruction in esophagus, then again it is not indicated. In case of pregnancy, this is not indicated because detailed studies and the effect of this capsular endoscopy in pregnancy is yet to be studied, and conclusion has not been drawn till now. Now this capsule retention, the capsule which is ingested for this capsular endoscopy, capsule retention is the main risk associated with the procedure, and this retention, this is procedural retention, this is defined as non-passage of capsule for at least 2 weeks or requiring targeted medical, surgical and surgical intervention or endoscopic intervention to remove the capsule. The risk of intervention of this retention of a capsule varies and depends on indications for the procedure. Suppose if there is obscure GI bleeding, or if there is suspected small bowel obstruction, then in these cases the risk of retention will vary. Now, what are the symptoms, risk factors for capsule retention? Now, what are the risk factors for capsule retention? One is obstructive symptoms, Crohn's disease, in which there is formation of stricture. There is a small bowel resection. As a result of radiotherapy, if there is formation of stricture, or if patient is regularly using non-steroidal anti-inflammatory drugs for more than 6 months and has developed some stricture, then in these cases this is risky to there is risk to do capsular endoscopy. Now, in those who have risk factors for retention, gut patency can be determined prior to capsular endoscopy, prior to the use of this capsule. So you will have to study prior to the use of this capsule, and you have to rule out all these obstructive causes. Now, one of the risk of capsular endoscopy is capsule aspiration. Now, the incidence of this capsule aspiration is 1 in 1000. Sometimes there is aspiration of capsule in respiratory tract. So in that case, you will have to go for bronchoscopy to remove the capsule. Now, some other risk factors are, which are relative risk factors, are weak or absent cough reflex, neurological swallowing disorders. It should be avoided in neurological swelling disorders. Age over 75 years associated with some neurological disorder. Elderly patients who have history of dysphagia and who have history of post meal cough. In these cases, capsular endoscopy should be avoided. Now, in certain cases of coronary artery disease, in cases of cardiac disorders in which we are using pacemakers or implantable defibrillators, in this case there is potential risk of this capsular endoscopy because there is electromagnetic interference because of the pacemakers and defibrillator which are placed inside the heart. So if you will give capsular endoscope in these cases there will be loss of signal, there will be loss of image in between, so you cannot make diagnosis, you cannot study properly the images, so it should be avoided in these cases. Now, what is endoscopic capsule placement through endoscope? Now, in certain cases, if there is suppose gastric transit is delayed, or if there is gastric outlet obstruction, or if there is difficulty in swallowing, or some gastric surgery has been done, still we want to do this capsular endoscopy. Then, in these cases, the capsule is directly placed into a small bowel, and this is performed via a gastroscope. Through the gastroscope, this capsule is taken down up to the small intestine, and there it is left, and then scope is removed. And capsule will do its work further as it goes down into the bowel and will provide pictures of the bowel. Now, in this capsular endoscopy, what are the pathological findings you can find? As the capsule proceeds from esophagus down to stomach and duodenum, it will collect the pictures of stomach, duodenum, small intestine, large intestine, and then it will pass out. When it goes from stomach and duodenum, it will detect various gastric pathologies like gastritis, gastric polyps, gastric antral vascular ectasia. When these are detected, they should be documented in the report. Secondary lymphangiectasia. This is also detectable in the capsular endoscopy. Focal lymphangiectasia. Secondary lymphangiectasia is the feature of many intestinal and extra-intestinal diseases. It is patchy, focal, or diffused. Pathological association should be considered when it is associated with denuded mucosa or clubbed mucosa, distorted mucosa, erosions, ulcerations, petechial hemorrhages. Secondary lymphangiectasia can be caused by infections such as Whipple's disease, atypical mycobacteria, human immunodeficiency virus, tuberculosis, in Crohn's disease, in non-steroidal anti-inflammatory drug use, in tumors, lymphoma, carcinoma, and various metastases because of radiation enteritis, and even in right-sided heart failure because of congestion. In capsular endoscopy, you will have to assess the villus atrophy. This is fairly common finding. It has a spectrum of appearance, reduced visibility or absence of villi. Villi may be absent. There may be fissuring, there may be scalloping or loss of circular folds of the small intestine. You can get a mosaic pattern. You can get nodularity of the mucosa when you are observing the villus atrophy. So you will not get villi, you will get nodularity of mucosa, you will get mosaic pattern, you will get fissuring. So you will have to observe these things in the photographs in the video. Common causes of villus atrophy is celiac disease, but other causes should be considered, and these includes drug related enteropathy, autoimmune enteropathy, certain drugs like angiotensin II inhibitors which are used in as antihypertensives, olmesartan, respiratory refractory celiac disease, ulcerative jejunitis, enteropathy associated with T-cell lymphoma. In these cases, there is villus atrophy. In Crohn's disease, suppose if patient is of Crohn's disease and you have done capsular endoscopy, then in those cases you can get mild inflammation. Crohn's disease is commonly found at capsular endoscopy in mild cases, and its appearance varies widely depending on the site of lesion and severity. The earliest changes which you can get in this Crohn's disease is erythema, edema, loss of villi, denuded mucosa, erosions, and associated lymphangiectasia. Sometimes there is moderate inflammation. Then, in this moderate inflammation, small bowel changes become more pronounced with more extensive involvement of mucosa. Ulceration is extensive, erosions are extensive. Sometimes ulcers are epithelial. They may be linear, they may be rounded, they may be irregular. So shape of ulcers will also vary. Shape of erosions will also vary. Later on in this moderate inflammation, you can get mucosal fissuring, cobblestoning, and multiple longitudinal ulcerations running parallelly in the mucosa. If there is severe inflammation, if inflammation is severe, long standing, then strictures will develop. So these strictures are visible in capsular endoscope, and sometimes these strictures may delay the transit of capsule. Ulcerations, edema, and hemorrhage is also visible. Now, in this Crohn's disease, there is one activity index, which is short form of this is CECDAI, that is capsular endoscopy Crohn's disease activity index. With the help of this, you can assess the inflammation and you can grade the extent of disease. Now, this grading is depending on inflammation, on extent of disease, presence of obstruction, stricture or erosions. So we grade this. Now this one grading is Lewis score. In this grading, one is Lewis score. Lewis score is assessment of severity of inflammation by presence of extent of villus edema, how much villus is edematous, how many ulcers are there, and how many stenotic lesions are there. And this score is done if it is less than 135, it is normal or insignificant. If score is between 135 and 790, it is mild, and if it is greater than 790, then it is moderate to severe. This is the Lewis score. I will not go in detail of this Lewis score, but with the help of this Lewis score, we can grade the disease, and with the help of CAPSULAR, we can assess the extent of disease and disease extent. Now, role of this capsular endoscopy in non-steroidal anti-inflammatory and enteropathy. Now, this non-steroidal drug-induced enteropathy can present with occult bleeding, it can present with protein-inducing enteropathy or anemia. So, in these cases, when this capsular endoscopy is done, it can detect the enteropathy. It can detect the changes which are pathological changes of enteropathy. If there is erosion, it can detect erosion. If mucosa is denuded, it can detect that. So they have a typical appearance. There is typical appearance at this capsular endoscopy. Circumscribed dilatation of capillary vessels in mucosa or submucosa is there. They have typical arborization of vessels and may have active bleeding in the vicinity, in the nearby area. You can see red spots with less distinct features are also visible. Now, there's one pathology known as Michel's diverticulum. This Michel's diverticulum results from presence of embryonic vitelline duct and has a prevalence of up to 3% in adults. So, with the help of this capsular endoscope, you can study this Michel's diverticulum. It may be asymptomatic or it may present with bleeding. Its typical appearance in capsular endoscopy is that of diverticulum in mid distal small bowel. Usually, it is located about 60 to 90 centimeters from oral cavity and may be associated with ulceration due to the presence of ectopic gastric mucosa. Sometimes diverticulum is not easily seen due to ulcerations. So on the capsular endoscope, you can see a diverticulum in this particular region. Small bowel tumors. In small bowel tumors, these are about 1 to 3% of gastrointestinal malignancies with prevalence of 2.4 to 8.9%. So they often have non-specific presentation, but the symptoms when present, they include abdominal pain, iron deficiency anemia, weight loss, intermittent bowel obstruction, intussusceptions. So in these cases, capsular endoscopy is useful. Sometimes there is diarrhea in these cases, flushing, wheezing. So capsular diagnosis. Now, in various types of polyps, there are various types of polyps in small bowel. They may be multiple, they may be familial adenomatous polyposis or isolated polyps, sporadic polyps. So in these types of polyps, capsular endoscopy is useful. Now these polyps may be inflammatory, they may be hyperplastic, they may be adenomatous, they may be inflammatory, they may be hematomatous. So one of the drawback of this capsular endoscopy is that you cannot get the histopathology biopsy specimen during the procedures. So in this capsular endoscopy, these various lesions can be marked out but cannot be diagnosed histopathologically. Hematomas of small bowel, they occur sporadically, but most of them are the part of polyposis syndromes. Similarly, small bowel adenomas, they tend to occur predominantly in duodenum. So you can detect them with the help of upper GI endoscope. Otherwise, with the help of capsular endoscopy, they are visible, but I said that one of the drawback is you cannot take biopsy. Similarly, adenocarcinoma accounts for about 30 to 40% tumors of small bowel, and they are also commonly located in duodenum, may occur elsewhere in small bowel, and in these cases again it is difficult to prove, but they are commonly associated with ulceration, stricture, and bleeding. Other diseases associated with are familial adenomatous polyposis, Peutz-Jeghers syndrome,